Hello, I'm Dr. Catherine Ruddy from Mayo Clinic, Rochester, and it's my distinct honor to present to you our keynote speaker. Dr. Arif Kamal serves as the first ever Chief Patient Officer for the American Cancer Society. In this role, Dr. Kamal drives the coordinated efforts to accelerate progress against cancer through the organization's patient-facing activities. He's responsible for leading the American Cancer Society's patient support objectives and developing strategic plans to measurably improve the lives of cancer patients and their families. Prior to joining ACS, Dr. Kamal served for more than 12 years as an oncologist, researcher, and innovative leader at Duke University and the Duke Cancer Institute. I'm proud to say that Dr. Kamal completed his internal medicine residency and a hospice and palliative care fellowship at Mayo Clinic, Rochester. And he then went on to his hematology-oncology fellowship at Duke. He holds a master's degree in health science in clinical research from Duke and an MBA from the University of Massachusetts Amherst. I'd like to note that Mayo looks forward to working with Dr. Kamal as a major co-sponsor with ACS of a National Cancer Care at Home Summit at Mayo Clinic, Florida on October 27th. And we would love to have all of you join if interested in that topic. Our new Cancer Center Director, Dr. Cheryl Willman, is not able to be here with us today, but she is very much looking forward to meeting Dr. Kamal and working with ACS going forward. And I also want to take a note to say that it's really been a pleasure for me to be part of this program today. I've learned so much. I enjoyed all of the breakouts, and I really look forward to working with the Alliance going forward and applaud everyone's efforts to put together such a terrific program. So on that note, I will introduce Dr. Kamal and ask him to take the stage for our final keynote. Thank you, Dr. Kamal.
Well, thank you. That was very kind. And I asked Dr. Reddy to be brief because that's like the most 5 minutes like nerve-wracking moment that anyone has. And for those of you who enjoy listening to that, your own accolades, like good for you. I can't do it. So I appreciate the invitation back. As was mentioned, I spent a lot of my formative years here in the state of Minnesota and still have plenty of friends who are here. Some of my first dates with my now wife were at Lake Pepin, and the movie New in Town, which was supposedly filmed in New Ulm. Do you remember that movie, right, with the scrapbooking and the whole that? That came out when I was here as well. And then I've had lifelong mentors from my times at Mayo, but also with the great work that the U does and bone marrow transplant as an oncologist. I'm just so admiring of the things that happen in this state. And so when the invitation was given, I happily said yes. I think a lot about the future of cancer care, and I appreciate that you guys are working on your strategic plan for the next 5 years. And I think that's such a smart thing to be doing right now, because as I think back to when I trained in oncology about 12 years ago or so down at Duke, is that a lot has changed in a very short amount of time. And there was a time, 10 years ago or so, there were about 10 of us in my residency class at Mayo who were going into hem-onc, which was a pretty remarkably high number for a medicine residency class at Mayo because everyone went into cardiology. And so to actually find double digits of people going into oncology was pretty rare, and one would credit the mentors that we had as a class. But also, two, I think we were starting to see the cusp of innovation happening in oncology in a way that's been unlike ever before. So let me give you some examples. One is the number of new drug approvals, indications or major changes like black box warning, et cetera. I wrote an editorial for the ASCO Post, and I lost count at about 300 since I finished fellowship, which was about 12 years ago. To say that it's unprecedented is actually a bit of an understatement, because never in the history of time have so many drugs been approved for any single specialty, let alone actually in the history of drug approvals total. And that's really remarkable, right? And so you look at that pace of innovation and marvel at it for a second. And also realize that the problem that we haven't solved, just to give you the counter to that, is we have not solved the problem of uncertainty. And so what I mean by that is that all of us will know of a patient, for example, who had a very high, let's say PD-L1 expression just as a targeted way, who did not respond to a particular medication. And what we couldn't say to a person that we were talking to is, despite all these new drugs and innovations and interventions, that we cannot look another person in the eye and say with absolute certainty that a particular outcome will occur. And so while we're looking at this amazing space of innovation, it's also become harder to have a conversation with a person because so much remains uncertain. And so what it's required is that those of us in the clinical professions to have sharpened our skills in having this conversation where you can hold the promise of innovation and the angst of uncertainty both at the same time. And actually that ends up becoming the skill of the oncology professional, is being able to hold both things at the same time. So when I talk to my fellows, my residents, my learners about what makes this hard, I think probably 12, 15 years ago, what made it hard is you saw a person with stage 4 melanoma and you said, well, there's like 2 things I can do for you, neither of which are great. And the ability to prolong your survival is going to be measured in months. And the chance that you're going to respond to that is probably going to be under 50%. That's what made it difficult to be an oncologist, because the availability of those drugs was little to none, particularly in areas like pancreas cancer, melanoma, brain tumors, areas where we didn't see a lot of innovation. Fast forward 10 years, the challenge for us is not so much whether there's a pipeline of drug, but it's actually the nature of the conversation that's going to happen. It's going to be the moment where a patient says to you, but Dr. Kamal, I saw the Super Bowl commercial and it promised me, right, because people see themselves in external marketing. They promised me that I was going to respond to that thing. What's the deal, right? And I think that there's a lot of components of what we do, and that's important to remember, which is really the skill of being around communication. When people ask, like, why is it hard to be an oncologist? Clinical decision support is also part of that, right? It's like, how do I remember the 300 things that I need to know? So there's that component too. But there's also the communication part, which is like, how do you look another human being in the eye and tell them that there's a lot to be hopeful for? I can't guarantee you much of anything, but I'm going to be at your side regardless of the outcome, right? Those are like the 3 goals that I want to achieve when I'm talking to another human being. And what's important is that that takes time and it takes skill. And as we think about the future of cancer care, as you're doing your strategic planning, right, ensuring that all of the people that are part of that ecosystem have that skill is going to be super important, right? Because at the end of the day, what chemo to give a person, I can look that up, right? What supportive care drug to give a person, I can probably find that as well. But how to appropriately respond when a 30-year-old woman is diagnosed with metastatic breast cancer and sits in front of me and says, why is this happening to me? Pausing and making sure that the learners in the room don't respond with something related to a P53 mutation, which, by the way, for scientists is where they go, right? So they start to think about, oh, well, you know, what happens is the BRCA gene, da-da-da-da-da-da-da. How many people in this room believe that when that 30-year-old woman asks me that question, why is this happening to me, that she's asking a question about a genetic mutation? Yeah, I know, you laugh, right? But like, I've been in the room where I've actually had to hold the resident back, very well-meaning, who was jumping in to answer that question. And so a lot of what we realize around communication, right, is the ability to demonstrate rapport and alignment and empathy and compassion and support that is agnostic to outcome, right? Because that's really what it is. And that is actually the skill that is really required. And as you think about, strategic planning and sort of the future of this, right? What I think we have to get correct, and what I worry that some will not, is not really this issue of availability of drug. I mentioned that availability of drug, availability of expertise, availability of intervention was what we've been working on since the 1950s, since the invention of mustard gas, right? Like, since oncology really formed, that's what we were paying attention to. And I believe that now, where we're pivoting is from availability to accessibility. Okay, so let me tell you why. So actually, when I was at Mayo one of the studies that one of my mentors, brilliant idea, I came to him and I said to Matt Getz, I want to do a study about how oncologists make decisions related to testing and treatment. And this was at the time where this test, which was relatively new, called Oncotype DX, had just come out. And Oncotype DX had this promise that it was going to look at genetic alterations and give a sense of whether people should receive hormonal therapy alone or hormonal therapy plus chemotherapy. Now, that's not a minor difference, right? And we had online calculators at the time and so on. But this idea between a pill, right, once a day versus 4.5 to 6 months of chemotherapy is not a minor difference, right? And for women who undergo chemotherapy, their risk of things like secondary cancers, neuropathy, and other things can be lifelong. So it's not a minor thing to make the difference around. So what we did was we took the first handful of Oncotype DX cases that had been done at Mayo across the entire health system that included Florida, included Arizona, and we looked at those cases and we sent them to about 6 very, very, very famous breast oncologists in the world who I got a chance to meet, and I just sort of, fangirled for a minute over, oh my gosh, I'm talking to Eric Weiner, who's now the president of ASCO. And what we did was we gave them the cases and said, well, what would you do? And people told us, and they said, well, here's the 30 cases. Here's the people who get hormonal therapy only, and here's the people who get hormonal therapy plus chemotherapy. So then we did a clever thing. And so, and it was interesting. So if you were in some institutions on the West Coast, the chance that you got chemotherapy out of these 30 cases was 80%. If you were in the Midwest, it was different. If you were on the East Coast, it was a little different. But the point is, it mattered where you went and who you saw in terms of determining, and they all got the same information, right? Like I didn't give them anything different. But that recommendation was different based on kind of where you got seen. So then we did a clever thing. We took those same 30 cases, jumbled them up, 6 weeks later, sent them back, and told those oncologists that these are a whole new set of 30 patients, and asked them what they would do. Now, this was clever because it was this big ruse, because we didn't change the patients at all. All we did was change the day of the week and the time that they got to see the patient. Anyone want to guess what happened? 20% of the time, they changed their mind. Why? Did some new piece of evidence come out? Nope. 6 weeks apart. I promise you, no big study had come out. Did I change the cases? No. So you took a person who said, this is how I would treat these 30 people, and asked them 6 weeks later, and they 20% of the time said, this is how I would treat them differently. So what it demonstrates to you is that there's a lot of variability to access to high quality care or decision making, and that's just variability that's day to day within the same oncologist at the same institution. That individual is going to change their mind demonstrates what could potentially happen. But what we also know is that there's variance in accessibility to high quality care across the country too. If you look at national payer data of the percent of patients who are oncology patients who are on some sort of pathway, some evidence-based pathway, the best published data out there only shows that number getting as high as 60%, meaning 40% of patients are not on some sort of pathway. And I don't mean payer pathway for cost containment. I mean pathways that are really like demonstrating the best evidence that's out there. So we know that variation exists even when people get to the best tertiary care centers. We also know from a study that I did with a handful of students, and this, by the way, if you ever work with learners, is a pretty cool idea. So a bunch of MBA students, who I teach in the business school at Duke, came to me and said, we want to look at sort of how cancer care is delivered. And I said, well, then you should just call cancer centers. It's not that hard. And what we should do is we should make up a case where you are the child of an adult with liver cancer. The reason we chose liver cancer is because a person with liver cancer could be seen by a gastroenterologist, a hepatologist, a surgeon, a medical oncologist. There's multiple inroads into a cancer center where someone with liver cancer could come in. We said, well, why don't you call, and we're going to secret shop 50 or so major cancer centers in the country and ask ourselves the question, can we get to the care we want just by calling and asking? So what's interesting is, right, again, learning from learners is really fantastic because you see the world through their eyes and they ask questions that maybe you never thought to ask. So I set them forward. I gave them the script, and I set them forward, and I said, go call these cancer centers. Ask them, when can you get the appointment, and what are the supportive care services you can get access to, amongst a number of other questions. So they come back to my office, and one of them actually happens to be an Olympic diver. She had won silver in London. And she sat in my office and she said, you know, I've done a lot of work in my career training. I've been in a lot of high anxiety positions. I've never felt as anxious, right? She was at the Olympics, like she medaled at the Olympics, as anxious as calling that number and listening to people essentially judge me because I'm talking about my mom who has Medicaid. And I was like, gosh, how do we capture that? She said, I don't know, but I could tell that they were talking to me differently the moment I said that. I was like, yeah, no, it doesn't surprise me, but it does disappoint me, because these are some of the best cancer centers in the world. We published this paper in the Journal of Oncology Practice. So what else was interesting was that the time it took to get the first new appointment, well, so first of all, the phone call took an average of 20 minutes. The call was dropped an average of 2 times, meaning that you had to call back, and that the first available new appointment on average was 2 to 3 weeks out. Which, as you think about access to cancer care, as I can tell you about all the great drugs that exist, there's not a lot of people I know who will choose to lose sleep for 2 weeks before they get to see an oncologist. And frankly, I don't think that feels right or fair. And so when these students come in my office, they came with that level of injustice that I want people to have. They just haven't lived long enough to have that sort of erased or someone tell them, no, that's normal, that's how the world works. They hadn't learned that yet, and I wasn't gonna teach them that. So they come to my office and they're like, this isn't right. It's like, tell me about it. They're like, 3 weeks to go to some of the best places in the world doesn't make sense. And I was like, I hear you. And treating people differently because who their payer is, it's like, yep, I hear you. We need to publish these and put them out into the world, because really the issue is really around accessibility. But what I'll also point out is that access to supportive care services in this study, where we asked about genetic counseling, palliative care, caregiver support, is that 20 to 30% of the time, now these are NCI designated cancer facilities, so they have to have these services that I listed. They tell the NCI that they have them, and the reality is they do. But the difference between something exists and you have access to it is what we're talking about right here. And the fact that there's a moat between the two things is where the injustice in cancer continues to occur. So in the study, we published between 20 and 30% of the time, a person was told a service does not exist, or the person on the other end of the phone editorialized and said, you're not eligible for, you don't need, or in the case of palliative care, your mom's not dying, so why would we refer you there? Which, to an oncologist and a palliative care doc like myself, could not be worse than nails on a chalkboard. And so what this continues to demonstrate, right, is that we can put a lot of effort into building things, creating things, putting things into place, and still what we find is that not everyone has access to it. Let's talk about social determinants of health for a second. So, really for the first time in payment history, in large-scale payment history, you can see now the federal government and others really requiring that as health systems, we acknowledge the fact that the way people live and where they live and how they live affects their cancer outcomes, that we all play a role in assessing and addressing that. And I think that the first part of that sentence may have been known for a period of time. In fact, health services researchers have really been talking about that. We know in oncology, for example, there's a paper in JCO 4 or 5 years ago that demonstrated that if a patient does not have a primary caregiver, that stage for stage their mortality is worse. ACS just published a paper we presented at ASCO demonstrating that for cancer survivors, that if they report loneliness or social isolation, their mortality rate goes up when accounting stage for stage. And so what we start to see is you can give people the right drugs and the right care at the right time, at the right place, oftentimes at significant cost, financial and otherwise. But that if we don't address the other components of how they live, where they live, and what challenges they face, we will not be able to solve the ultimate goals that we have related to quality of life and survival. For example, I'm a breast cancer oncologist. In the breast cancer world, we've known for a while now that what we do to women, particularly with chemotherapy, increases their risk of gaining weight during that period of time, right? We give people fluids, we give people steroids. We have oftentimes told women, you have a cancer patient, so we kind of bubble wrap them and say, like, sit in your house, stay away from people, right? And play the sick role. We don't say that deliberately or directly, but that's essentially what we're implying, play the sick role. And what happens is that the average woman who goes through the breast cancer chemotherapy gains between 10 and 15 pounds. And I'm not talking about aesthetics or beauty or anything else. I'm talking about what that means as it relates to their risk for recurrence. If a woman who gains 10 to 15 pounds during that course does not return to baseline weight within a year, the risk of breast cancer recurrence, meaning the disease is coming back, goes up by a third. That's major, right? Now, how many oncologists, including myself, actually talk to patients at length about how they live and how that may be helped or hurt by their habits and their weight, for example? Again, we're not talking about physical beauty of any sort. We're talking about cancer risk recurrence. So how many times do we as oncologists, I'm going to tell you for me, very infrequently, so I'm going to point the finger at myself first, really think about prescribing like a gym membership, right, meal delivery that focuses on healthier eating to help people get to where they need to go with the lens of improving their cancer outcomes. Very infrequently. But what we see now is actually, I believe, an obligation for health systems to be a part of the solution. Because fundamentally, this idea that we're going to do some things during 1% of their life, ignore what happens in 99% of their life, and then be surprised when outcomes aren't what we expected it to be, that's insanity. It's just insanity. When someone comes to my clinic, if I only pay attention to what happens in that clinic and then I am surprised that these other things occur because they're socially isolated, lonely, gaining weight, don't have access to proper nutrition, or they face other systemic barriers in the way they live, isn't, I believe, my role as a healer. And now we're starting to formalize that in things like payment programs and the way health systems are approaching this. Let me talk about social isolation for a second, because I think it's super important as you guys are thinking about your strategic plan that we talk about this. So let me tell you the story of a myth. Here's the myth. When people say to me, one, oh, you're an oncologist, that sounds really sad, and I say, you want to hear something else? I'm a palliative care doc, and they're like, oh my gosh, that must be really terrible. And I'm like, no, it's actually really fantastic. Why? Because I have this enormous privilege of being able to be with a person during a time where they need humanity around them, and I get to be a part of that team. How amazing is that? Are there days that are bad? Yes. Are there moments that are bad? Absolutely. I'm not going to tell you otherwise. But really, when you're the witness to distress of another human being, right, there is some beauty in it because there's parts of that we believe we can fix. And even for dying patients who I take care of every single week, there is hope in that as well, right? So I just want to be really clear here because I have to say this to any audience when I talk about palliative care, is that palliative care does not take away hope, so let's just get that out of the way up front. Let's talk about hope as a construct, though, because I think it's a really important way for all of us to communicate. I started with communication skills. Why does palliative care not take away hope? It's because I didn't give them the hope. I don't have anything to take away. Hope is a dynamic construct. Why? Because I have a 10-year-old daughter. Let me tell you why that matters. As a 10-year-old daughter, my 10-year-old daughter hopes that when I coach her soccer team, which I do, that I won't make too many dad jokes on the sideline. That's what a 10-year-old daughter hopes for. When she's 15, she's going to hope to pass her driver's test, right? When she's in her 20s or 30s, she's going to hope to maybe find a partner, and so on and so forth. So what the things that I hoped for, right, when I was 24 and I met my future wife, that she would say yes when I asked her to marry me, that's what I hoped for then. The idea is that what we hope for changes based on the circumstances we're in. I have been at the bedside of dozens of patients who have been dying alone, and they have hope as well. Hope for whatever's going to come next, hope for being comfortable, et cetera. So I want us to all just reframe this concept of hope. It is not something we give someone or take away. It is something that we acknowledge, and for some people we have to reframe. And that's what we talk about, what I talk about with patients is, as you think about the future, what are you hopeful for? And as you think about the future, what are you worried about? And as a communication technique, let me just tell you, it's a really good one because it helps diffuse a lot of situations. I'm going to veer off social isolation. I'll come back to that for a second. Let me tell you about the woman who was in her 30s with metastatic breast cancer. Now, she was sent to my clinic. I'm a breast oncologist, but a palliative care doc. She was sent to my clinic because she had been through 5 different chemo regimens, had not, the regimens had failed her. And just so you recognize, I believe language is really important, right? People don't fail their cancer therapy. Their cancer therapy fails them, let's just be clear. And so hope, right, I talk about very carefully too. So for her, she came to my clinic, and oftentimes, like a lot of things in my clinic, I don't get a lot of backstory of why they're there. I just generally have a sense. So I knocked on the door and I walked in. There are 2 kids, probably 6 and 4, sitting in the room. She's by herself otherwise as an adult. And instantly, I think there's a lot of things that skilled clinicians do, and this is what I've learned from my mentors, that may appear to be observation or small talk, but there's a lot of data that you're actually capturing. So for them, I got the nurse to take the kids out to a different room and to keep them company, because I could tell this was going to be a really important conversation. You haven't been through 5 lines of chemotherapy, come to see me and think that this is going to be a meet and greet, because it's not. So I sit her down, and she starts, like, you know what a clinic exam room looks like, right? So I've got a little rolling chair, and I'm about to sit down. And before I sit down, she pulls out that one finger in healthcare that gets everyone's attention. It's this one, in case you thought it was something else. It's this one, which is the pointer finger. Because as a physician, I'm not generally used to people pointing at me. It's generally pretty aggressive. She decided to point at me and said, "I know why you're here." Now, let me tell you, like, the normal culture of a doctor exam room, right, is that I get to talk first, is generally the rule. I get to sit down before you start talking to me, and generally you don't, like, point at me, kind of as a social contract. So when those things don't happen, I'm like, okay, all right, we're in a different place now. So I'm sitting down, she does the "I know why you're here." Now, as a communication skill, right, it may be attempting to sort of say, well, tell me why you think I'm here. I said, you know what? Before we talk about that, I'd love to get to know you better. And she goes, well, you probably read my chart, blah, blah, blah. I said, no. I want to get to know who you are better. I read your chart. Tell me about you. She was like, well, what do you mean? I said, well, tell me what a good day looks like. Oh, well, and then she tells me. Plays with her kids, right? She likes to cycle. She starts to tell me what a good day looks like for her. Great, that's really important for me to know. Why? Because I think as a healer, what I'm trying to get her to is more good days, right? And there's 2 parts to that sentence. More, which could be length of life, but also more good, right? That maybe length of life is not something I can change, but I can make more of them better or good days, right? So she's talking to me. We're talking. And a great sort of technique when you're in a situation like that, which appears to be very like you're in conflict, because generally if someone's pointing at you, you're in conflict. I'm going to tell you that up front. And so in a moment like that of conflict, right, a really great question to ask a person, particularly trying to get to the point, is what are you worried about? Because it's interesting, as part of the human condition, we react more to worry than we do to hope, right? Because when we're like just really mundane thing in my house, like trying to figure out like what we're gonna have for dinner or where we're gonna eat or that kind of thing, right? Like people worry more about missed opportunity than they do about something in particular they really, really want. It's just sort of how people think. So when I asked her the question, when you think about the future, what do you worry about the most? What do you think she said? Her kids. Now, a lot of, particularly when I'm talking to learners, they presume that people are going to say, well, they're going to worry about not living longer, the prognosis, blah, blah. Here's the reality. I've been doing palliative care for 15 years as an oncologist. I am yet to find a person where I ask them when they're worried about the most, that they don't name their family, their independence, or how they're feeling. That's what people talk about. So that's what she talked about. She went on to share that for her, what she was worried about is that she was going through a divorce, which is not uncommon, unfortunately, during a cancer journey, and that she was worried about who was going to have custody of her children after she had passed. Now here's what's really interesting, right, is that one question got to the heart of what we were going to end up talking about, and it didn't require me to presume all the things that I think people would have wanted me to presume. She doesn't understand how sick she is. She doesn't understand how important time is right now. She doesn't understand. No. The thing is, she does understand. We just weren't asking the right questions. And when she had been insistent with her previous oncologist before coming to me about going from 5th-line chemotherapy to 6th-line chemotherapy, that all she was doing was pulling out the only tool that she had in her toolbox, which is to ensure that her children and that she have the time to get her affairs and custody in order. She saw the only tool in her toolbox was to take late-line, very late-line chemotherapy to buy the time to make that happen. Now that's what we figured out in approximately 10 minutes. And so what I did was position really quickly our visit together from that, which was going to be to talk about Kaplan-Meier curves or something else, which is not generally what I talk about, but to actually talking about how our medical legal program, which is what we had established at Duke, could help her with this issue of custody, and that I was going to support her regardless of what was going to happen. And demonstrating allyship to her was what she was looking for, because she had run into a lot of clinicians and others who were looking for reasons to say no, and I was saying yes. But I was saying yes to something different than she had originally thought. I was saying yes to, I'm going to help you. And I said, I'm worried that 6th-line chemotherapy is not going to reach your goal. Why don't we focus on this other thing? But I'm happy to talk to you about chemotherapy once we get these things in place. Let's do that, that's what she said. Got her connected with some law students at the law school at Duke, which is a very good law school. Connected with some pro bono attorneys in the community. They got her custody transferred to her parents because her ex-husband was a pretty terrible guy, as I came to learn, for reasons we won't talk about, but you will all agree he was terrible. And she ended up dying 6 weeks later. Now, is that a sad story? It is, in that we don't like people losing their life. Her kids got to the right place, helped her in the right way that she needed. We never talked about chemo again, though I could have. And can I talk to you about 6th-line use of eribulin? Of course I can. That's what I was trained to do. And could I prescribe it? Of course I can. That's what I'm able to do. Is that what we did? No. Was that my choice? No, that was hers. And in that ability to see people for who they are, to give them agency, to listen, to demonstrate concern for their worries, is fundamentally where we want cancer care to be. And I believe that what I've just described to you, if we said that out in the sidewalk somewhere, people would say, well, of course that's what cancer care should be. Isn't that what it is now? Well, no, I think we've got some room to move. I mentioned social isolation. Let me tell you the myth around that. So many of you may have read the book Together by Vivek Murthy, who's the current Surgeon General. I love that book, and I highly recommend you read it. Because I think it's very apropos to where we are as a country. My wife's an ICU doc, and it was hard to be an ICU doc in the past couple years. My wife is fantastic in so many ways. And if you met her, you would like her instantly more than me, which is really glad I'm why she's not here, and you get to listen to me speak. But she's fantastic. And she took care of a lot of people, right, who had COVID and were ventilated and so on. But what she learned is how isolating that is as healthcare providers. And what we saw is for healthcare providers and administrators and so on, amazing sources of pressure that occurred at a time where health systems lost a lot of money, actually post-COVID, and still continue to have financial difficulties. At a time where burnout rates for oncologists and ICU docs and so on skyrocketed, and where people physically felt less connected, right? Which is why I love the fact that we're all in the room together. But here's the myth about cancer. The myth is the concept of the cancer rally, right? What's the cancer rally? The cancer rally is, oh, I heard that Cindy just got diagnosed with cancer. I'm gonna start the meal train, and I'm gonna create a visit list, and I'm gonna do this, and I'm gonna do that, and I'm gonna do that. One, I believe that the cancer rally is something that people with privilege can experience, sure. I have plenty of patients where that cancer rally does not occur. So we have to acknowledge that. So when we talk about equitable care, let's take that concept that everyone rallies and let's just shove that out the door, because that's not what I experience when I talk to my patients. By the way, just so you know, when you hear that I see patients at Duke, you're probably going to envision something. I promise you it's much different than that. Right, 20 minutes outside of Durham, I've not been able to give chemo to patients because they have dirt floors and outhouses, right? So the diversity of the patients I take care of is much more than you might think. So the cancer rally, let's throw that out the door. The other issue, though, is that cancer is continuing to become a chronic illness. And so as we think about the strategic planning for what cancer care should look like in the next 5 years, we have to acknowledge certain things that are happening. One is that because of all this innovation, people are living with and oftentimes dying of other things, not necessarily cancer. For example, 10 years ago when I was trained, the response rate to a phase 1 clinical trial, this is what I was taught, meaning that if someone signed up for a phase 1 clinical trial, the chance that it would work for them in some way was 8%. And that's what I've been teaching people till about 5 years ago at ASCO. Some of the first PD-L1 trials in melanoma, like 50% of people are still alive 5 years later with metastatic melanoma. And if you looked at the data now, that's plateaued, meaning the people that responded are still responding, which is remarkable, because you're looking at durable responses close to a decade with metastatic melanoma, with a single drug, maybe two. That's pretty remarkable. But cancer care has not been developed as a chronic illness. It has not. We've talked about survivorship in this, that we're going to pass them on to primary care physicians. That doesn't happen very often. We've talked about the cancer rally, which, if it happens, is time limited. When I talk to my patients, they do not tell me that the meal train still occurs 6 months later. I've never heard of a meal train still occurring 6 months later. And yet the person may still be getting, for example, in the case of colorectal cancer, very much likely they're still getting chemotherapy 6 months later. So when we think about the support structures, society-wise, health system-wise, oncology-wise, we've not built a cancer care delivery system to address cancer care as a chronic illness. And that's actually the pivot that we need to take. So what other pivots are involved in that? Well, one is we have to address social isolation and loneliness. The latest data demonstrates that 50 to 60% of cancer patients report social isolation and loneliness. I told you that it affects the outcomes, too, of survivors. And that unless we break this myth open, people will not lean in, because there's this idea that everything's fine and okay. I take care of patients 10 years out from their breast cancer therapy, and I can promise you for many of them, things are not yet fine or yet okay. Right? And so that long view is what we have to think about. The other component of that is about where we deliver cancer care. Dr. Reddy mentioned our Cancer Care at Home Summit that we're doing with Mayo Jacksonville. There is a very big push, many of you may be aware of this, of moving cancer care to the place people call home. It is messaged in this idea of person centricity, which if it is true, is a great goal to meet. But there's also concern that what could be happening is that you're shifting the effort that's needed to deliver care onto the caregiver, who now has to do the things that maybe others within a cancer care team, within an infusion suite, was doing in the first place, and that you've moved that over. There are a few health systems in this country who have not yet published their data, so I won't share who they are, but they are pretty big name centers where between 20 and 25% of their cancer infusions are being done at home. So when I first heard that, right, all the things of like, how in the world do you give Abraxane at home? I don't know, they don't. But can you give pembrolizumab at home or a PD-L1? Yeah, I think you can. So that's the other pivot that's happening here as you're thinking about that strategic plan for the next 5 years, is site of service change. In 5 years from now, I'm going to predict, and I've done this, why? Not because I'm smart, but because I listen to venture capital and private equity who are putting billions of dollars into this shift, that I've heard from their leaders a movement to between 1/3 and 50% of all cancer care actually being delivered in a person's home within the next 5 years. And if you invite me back 5 years from now, I'm probably going to tell you the update on that prediction. I think it's going to be true. Because what we're seeing that happen is across the cancer continuum. You're seeing that with home HPV testing. You're seeing that with finger stick PSA. You're seeing that with home colorectal cancer screening, which we've had for a while. You're seeing that with home diagnostics. You're going to see an explosion in multi-cancer early detection, which will be a blood test, not probably indifferent or different from sending a vial of blood from your house or a finger stick from your house. So that's cancer prevention, early detection. I'm talking about infusion in the home. Imagine everything in between. And I think fundamentally what we're going to see in the next 5 years is, I hope, more person centricity. I hope more acknowledgement of the chronic illness that is cancer. Blessingly so, that's the case, because that's really fantastic. And third, I think you're going to see the concept of the cancer center being the hub of care to be much, much, much more decentralized. What you're seeing in parts of this country is cancer centers are buying up urgent cares to do infusion in places closer to home, if not home. You see nursing home companies actually buying infusion centers to do that as well. You follow the money and you'll see exactly how this is happening. And so what am I concerned about? I'm concerned that those supportive care things that people receive when they walk into a cancer center, like my clinic, like genetic counseling, like caregiver support, access to a social worker, that those will get cut out when we see cancer care only as an oncologist being a chemotherapist, which is not what I am, much more than that, and that a cancer center being only the place where chemotherapy is being given. And so what we have to ensure, all of us together, is that what we believe is comprehensive cancer care, what we believe is high-touch, person-centric care that is multidisciplinary in nature, that gets conserved regardless of where that care is delivered. And I'm personally on a mission to make sure that as some van pulls up to someone's house with a bag of chemo and it gets put into that person's arm, that someone's actually asking them, how are you doing? Because that's fundamentally what my infusion nurses do a really great job at Duke, and they do it better than I can, and we wouldn't have such great care if they weren't doing that work. And so as we preview the future, as you think about your strategic plan, please do keep those things in mind, because I think fundamentally there's abilities to do this wrong, and we want to make sure we get it right. So I just want to review here: variability at the oncologist level, variability at the health system level, not seeing people as person-centric, not having those communication skills, not thinking about all the different touch points that a person needs to have a good experience, and making sure that we close that gap between availability and accessibility is our challenge. So I appreciate that, and maybe we have a few minutes for questions. Thanks so much.
I am so moved. Thank you so much for being
You got
here.
it.
You mentioned that you were a fangirl of Dr. Weiner with ASCO. I am now a fangirl of you.
Oh gosh.
So
Okay.
thank you. And I heard you say in 5 years, if we'll have you back, we want to hear the reporting that you can give us. Everything that you say, you embody patient care and bedside manner and communication. You can see that and feel that. And as we think about the next 5 years and how we handle our cancer plan and the strategic direction that our state brings, you fuel us with that motivation. So thank you. I'm truly grateful for your guidance and help as being a healer. Thank you.
Thank you so much. Okay, it's too kind. It's too kind. Thank you. Oh, okay. One question? Okay.
I actually have a question. I appreciate that cancer is becoming a chronic illness. But just out of curiosity, how far are we? I hear that if treatment were to be considered as versus just prolonging life, that we are still shoveling our driveway full of snow with a fork and a knife. Mm-hmm. So in terms of that, in terms of hope in that aspect, how far are we?
Yeah, well,
with the refractory cancers, like you say, that
Sure.
don't respond, but I believe that there's a lot of tumor-informed alternative disease care that's available based on the refraction or the diffraction of each chemotherapeutic agent. So
yes.
how is that available and accessible?
Yeah, so, let me make an analogy to pediatrics for a second, because when people ask me, when are we going to cure these harder to cure diseases like adult cancers? I just want us to all remember where pediatric cancers was 20 years ago. So 20 years ago, the cure rate for pediatric cancers was between 15 and 20%. And we recognize that that's wholly unacceptable. So what happened is we made it standard of care to put everyone on a clinical trial. Every child in this country, it is accepted that they should be on a trial. And the reality is 85 to 90% of kids are on trial. So what happened over the next 20 years is we got that cure rate from 20% to 80% because of that reason. So for these refractory cancers, right, we're moving from going from 200 histologies to 2,000 genomic drivers. And for these trials, for many of them, they're going to be powered not in the thousands, but maybe 100. And so what you're going to have is someone who lives right in Marshall, right, but they need to get to a trial in Madison, right? Okay, so, or they're going to live in Fargo and they have to go to Florida because that's where the trial is going to be. So I think the other thing we have to think about is access to trials, community access to trials, and things like the Diverse Clinical Trials Act, which is stuck in the Senate right now, which is actually allowing sponsors to pay for things like travel and housing to get people to those trials. Because what's going to happen is there's a driver mutation in Florida that somebody from Fargo needs to get to. There'll be patient number 100. And then that's going to demonstrate there's a cure. Right now, right, for NCI opened clinical trials, 90% close for, right, inadequate accrual. So when people say, well, where's the cure to cancer? It's probably in one of those trials that had to close, right? Because it didn't, right? So, I mean, that I think, as you guys are thinking, sorry, I didn't get to that, to your planning, is it has to be all hands on deck to get people into trials. Because we've shifted, I mentioned that 8% response rate when I was a fellow for phase 1 clinical trials. At that time, clinical trials was thought of as being experimentation. And all the issues related to trust are accurate and true. But today, it's about access to innovation. A clinical trial is not about experimentation, it's about first-in-line access to innovation. And that messaging has not gotten out to the communities as much as it needs to. And so those issues about trust, which are very important, and familiarity, we have to change that narrative to also talk about if you want the best that's out there, then the clinical trial is what you need to pursue. And here's the organizations like ACS, mine, and others as an example too, who are going to help you get there. And here's the health systems that are going to think about how to make sure their eligibility criteria, for example, are not the barriers to enrolling in those trials. Language in our consents. I absolutely agree with you. I think that many of those consent forms are written in that frame where it was about the chance of response was under 10%, right? And I think that, I as a researcher who put people on trials, we have to think about finding that balance that really talks about first-in-line access to innovation while keeping patient safety and autonomy paramount, so on and so forth, that people have informed choice. But part of the informed consent should be that you should be informed that the next great thing could be there, one, and that two, we don't randomize people to nothing, which is what a lot of people are really worried about, is being randomized to placebo. And there's nowhere where I think that's acceptable in cancer care, and we don't do it. And that's the message that has to get out. And I would implore all of you, because Minnesota, I love it. It's a great state. It reminds me, being, having trained here, it's actually a lot like North Carolina, and I think about a lot of challenges. You've got big cities, and you got really small towns. And the thing is, you might have something really great here in the cities, but if someone out there in Thief River Falls, which I've accepted transfers from TRF plenty of times to Rochester, from Thief River Falls, don't know a clinical trial exists and they don't enroll, we can't help that person, right? That's fundamentally the problem. Yeah.
Thank you so much, spot on. Appreciate the talk.
Am I done? Yes. Okay, off the hot seat. All right, thank you. Thank you.